what can we do to ensure that the leaps that we've made in healthcare are available to all? So to discuss this, in conversation with Bright Simmons from Pedigree, please give a warm welcome to Abhijit Banerjee from MIT, Julie Dodd, President of Parkinson's UK, Lynn Davidson from the 2020 Microclinic Initiative, Katharina Hoch from Imperial College in London, and Hans Flew from MD Linking.
Okay, thank you all for making it this afternoon. I'm delighted to moderate this panel on the issues of medicines as a right. We've been able to assemble an extremely distinguished panel for the purpose of this debate. And my job as a moderator is purely to ensure that they get the time they need to make the very important points that I'm sure they're going to be making. If at any point you feel animated to contribute, just raise your hand and I'll make sure that you are allowed to make your intervention. Thank you. Since we don't have a lot of time, I'm not going to do the introductions again because it's already been done, so I'll jump right into it. Lynn, you've had a strong focus in your work on the human rights agenda, particularly the rights to medicines. Can you give us an overall picture, the way that you understand it, of where the globe currently stands when it comes to access to medicines? To your view, what are the big issues currently dominating that agenda?
Sure. Thank you, Bright. So my work is in Kenya, and I'm focused on maternal and infant health in Kenya. And so I've got an interesting story to tell you. So I guess I think of healthcare as a right. And I'll just say, in the U.S., I'm not going to talk about the U.S. I just don't want to talk about the U.S. So somebody else can do that if you want. In the U.S., we have a conversation that's, similar to the one going on in the U.K., except we're starting from obviously a very different point. So our issues, as our president would say, who knew healthcare could be so complicated? So I'm not going to talk about the U.S. So my work is in the developing world. So I'm just going to give you a quick example that sort of talks about where I think healthcare as a right is today in 2017. So if we think about healthcare as a right, if we can all assume that healthcare is a right, I'm going to suggest to you there might be a limit to that. And I think the limit comes from the fact that we have not yet decided that healthcare as a right really extends to the people who are the hardest to reach or the poorest in our society. And what I've seen in Kenya, so this is just a great example, and you can repeat this example across the developing world and elsewhere. In 2013, the government of Kenya decided that healthcare is in fact a right for maternity care. So maternity care is supposed to be entirely free for all the citizens of Kenya, and that was in 2013. In December of 2016, the doctors went on strike. That strike lasted for 100 days. And I'm not going to defend the doctors. Somebody here might want to defend or not defend the doctors who went on strike. What I will tell you is that one of the tickets to the forum, the value of that ticket would pay 2 Kenyan doctors for an entire year's salary, 2 of them, for the cost of the forum ticket. So, whether the doctors should or should not have gone on strike, I'll let you guys argue about that, but I'm just telling you the facts. So that strike lasted 100 days. When the strike ended, the nurses went on strike. That nurse strike just ended 5 months later. So we can say healthcare is a right, we're promising it to everybody, And in Kenya, they in fact did that for maternity care. So during the strike, we figure now that the maternal mortality rate doubled in the first 6 months of 2017 relative to 2016. It doubled. After years and years of pushing and chipping away at those maternal mortality rates, we are back into a really huge problem. Now, kids didn't get immunized during the strike. People were not getting their malaria drugs during the strike. Mothers didn't have prenatal care. The problems that we're going to see in the coming years because of that strike are enormous. So, yeah, we can say healthcare is a right. I think we have a long, long way to go to make that true in the developing world. And that's
saying that the reality doesn't match the aspiration. We have these aspirations of making it a right.
That is
but are we
exactly true.
Really, I mean, it's nice to say it's a right, but typically, you know, in politics, a right is something you hold against a government. You know, you typically hold a right against a government. But from the way I understand your framing of the issue, a right in this sense is something that society as a whole promises to people. And then sometimes the different parts of society are as incompetent in delivering on that right as possible. But Abhijit, you straddle the world of both academia and practice. So you've seen both the way that this rights debate has been framed. It's a human right, medicine's access. You probably know a lot about this whole idea of drug compulsory licensing, you know, the whole debate. But you're also a practitioner. I feel that as somebody also in academia, you have a very good insight into the theoretical limits of these claims that practitioners usually make, whether as activists or entrepreneurs. What would be your take on this idea that this rights agenda is perhaps different factions of society contending against each other, as opposed to something you collect from the government or you claim against the government?
Actually, I mean, I think it's, I love the way Lynn started it, because I think I want to go exactly down that path. I feel like you could say in a way that in India or Pakistan or Bangladesh or many other, China, healthcare, the government has kind of accepted that it's a right for many years. There is, in principle, a healthcare center within 1 kilometer of every citizen. Problem is, nobody goes to the centers. So we just did a survey of, you know, area of India size of France, and 89% of all visits are to private healthcare providers. Who are these private healthcare providers? They're people who have decided they practice healthcare. They don't necessarily have any qualification. 70% of them have no medical qualification. 60% of them don't have a high school degree. They're practicing medicine. Why do people go to them? Well, partly because the equivalent in the public sector is also pretty bad. The quality on both sides is pretty bad. Part of it is also that they give you time and attention. So in other words, what does healthcare mean? It means partly sort of the actual treatment of the disease, partly it's empathy. You come in, they don't yell at you. They talk to you nicely, they give you some time, and you go away feeling better. And one of the reasons, so I think that sort of in this world, these guys, so people are willing to pay money. The government service is actually pretty much free, whereas people pay real money to go to somebody who has no qualifications, but who has some empathy. And I think in that world, I mean, I think when we talk about healthcare, right, we have some idea that we're just going to open a spigot and healthcare will spout out. And that just doesn't seem like the world I know.
Good point. Hans, the way that I see it, one of the changes that the internet and new technologies are bringing to bear is this immense capability of individuals to acquire information about their own health. It's almost like a right to take care of yourself. That is slowly emerging. You know, I have a problem, I have a medical problem, I can go online and I can find as much about it. Now, in some respects, that's a good thing. You know, we should all be able to be empowered so that we can learn about our own healthcare and even contribute to making decisions about it. But then it's a very regulated industry. And it's one of those industries where you feel that the regulation is for the good. You know, very often it's very debatable who regulations are for. But for healthcare, it's very difficult to argue against regulations around quality, etc. How do you see that tension emerging in the world of technology, where people have the right to self-empowerment about their own health, but at the same time it's a regulated industry?
Thank you very much, Brad. Well, I was walking around I think, one of the big stages over there, and there were about 3 apps who are trying to make it possible for patients to connect directly with healthcare professionals.
Yeah.
And that's something which is present for I think about 2 or 3 years, but it's still more interesting, more important that the patient wants to connect with the healthcare profession itself. However, if there is another problem, we have to solve another problem at this moment. Healthcare professionals, we are the same. It's very interesting. There's this. We are a big group. We are about I think 100 million healthcare professionals in the world. We share our same. We are very similar. We have the same background of extensive studying. We talk the same medical language, and we have the same goal: it's treating patients. However, we are still so very disconnected, and that's I think a problem at this moment. We have to try to connect with each other, healthcare professionals, so that we can educate each other, so that we can consult each other and help each other in different difficult cases. I've got a very simple example.
MD Lincoln does.
Yes, and it's not only patient to doctor, but also doctor to doctor. A good friend of mine last year, his little girl, his little daughter of 5 years old, she developed a strange eye disease in the Netherlands, and we all think in the Netherlands we have one of the best health cares in the world. However, there was no doctor in the Netherlands who knew the cause of this problem. And her eyes turned bluish, the pressure in her eyes increased, and she had a lot of pain. So what did they do? They tried to contact a colleague in Germany, UK, and America. But no, of course, everybody's busy during the day. So, okay. The solution was send an email by Hotmail to these colleagues and wait for an answer. So it took 5 days. And after 5 days, they had to plan an operation. But 5 hours before the operation, they received the email. The plan of the operation was completely different because they knew what was going on, so they can make a plan for the operation. So there was a time phrase of 5 days that this disease was deteriorating, and this girl has some irreversible eye damage for the rest of her life. So we have to start connecting cross-border the healthcare professionals, not only the doctors, but also doctors to nurses, to start to help each other.
But to push back a little bit there, in the traditional system, if you are a doctor or a physician and you don't know what is going on, you refer to a specialist. So how did that break down in this case? Why did you not refer the situation to a specialist much earlier on?
Well, if I understand you correctly, so how are we going to solve this problem of which physician you are going to connect?
Yeah, no, I'm talking about the fact that the physician didn't know what was going on.
Yeah.
And why did they not refer the problem to a specialist much earlier on?
They did. They tried,
Oh,
but they
they
couldn't contact them. The problem is, of course, it's very logical. Well, I'm going to call my colleague in Germany, but this colleague in Germany, of course, he's busy too with treating patients.
Okay.
So there has to be some focus or some line that a notification. There is a question of your colleague that you know.
Yes.
Can you check it out?
Okay.
Can you answer me? And not an email by Hotmail which comes into your spam box or just accidentally read by your secretary.
But this is still very much one physician to another professional. What if that gets disrupted and you have patients going around looking for their own specialists and they take out the intermediary?
Well,
assuming the parents of the daughter, the woman, had more information, the lady had more information and they could find out specialists all over the world, then what?
Well, that's. I think that's going to be the ideal world. Just pop in your question and wait till every healthcare professional is answering your question. However, you need a database with the healthcare professionals who are also willing to give you that advice, who dare to give you that advice without seeing the patient, without talking to the patient, without touching the patient.
So there's a limit to the technology.
Absolutely.
Massive limit to the technology.
Yeah.
And Katrina, so the way I understand it, and I think Hans has done a very brilliant job in the illustration that he's given, we cannot depend on mere innovation alone in the technical domain to change this space. We need innovations also in the way that the profession is organized. What do you think about that?
Well, yes, I think an important issue in this debate is what does a sick person need? A sick person needs health and not necessarily health care. So if a sick person does not benefit or does not benefit sufficiently from the healthcare that is provided, then we should think very hard as a society whether we want to invest in this particular intervention, in this particular treatment. I think this is also an issue with all the health apps that are possible, and it is just an accounting reality that budgets are limited, that we need to set priorities. And I still think there is a role for good governance to set priorities and to decide on what are the best investments in health. Now we have, I think, now with the data that is available, with the methods of artificial intelligence and data analytics, we have incredible opportunities now that we didn't have 10, 20 years ago to inform this decision what are the best investments in health into the treatments that will generate the highest welfare for our populations.
So, but you're an academic, and for you, evidence is the holy grail. It's all about evidence. But when I look at a lot of the apps that I imagine, if we were to subject them to the same evidentiary standards that we subject, say, pharmaceuticals, all of them are going to go out of business tomorrow. I mean, very few of the digital apps do any randomized controlled trials. They really will not pass your benchmark for quality, will they, as an academic? Will any of the digital apps that are popping up all over the place, will they pass a gold standard randomized controlled trial?
Well, I mean, nowadays, with the methods that we have available, that is developed by my colleagues, by people that are attending this conference as well, we can do a lot outside of a randomized trial. We can do a lot with using observational data, with quasi-experiments, and we can deduct really the impact between an intervention and the effect that it has.
Okay. Yep. Julie, so, one fascinating development that we are seeing is what some might call convergence between the developing world and the developed world as far as chronic diseases are concerned. So in urban Ghana, the biggest rising chronic condition is kidney disease. And this is a society that has no idea what to do about dialysis. Ghana has 3,000 doctors for 27 million people. And this is just general practitioners, not that was specialists. I think last couple of years we had 3 urologists in the whole country, 3 urologists. And all of a sudden you have these societies having to deal with chronic conditions, including disease of the aging, and Parkinson's is obviously one of those. You obviously come from a developed world perspective. Do you think that the time is coming when, because of the conditions that exist in the developing world, they are going to have to solve problems that have plagued the West for longer, but quicker? So if Kenyans find all of a sudden they have to do dialysis, they can't afford the dialysis, the kidney management systems you have in the UK. Just not possible. So maybe the time is going to come when they're just going to go further along than you think, and you have to start looking.
Yeah, I completely agree. And I come from a UK perspective on this, obviously, but we do a lot of work internationally with other Parkinson's and neurological condition-focused organisations, and we see exactly that. So we see a lot of leapfrogging happening. It's the same as in any other developed world comparison with technology. They haven't gone through a lot of the kind of noodly steps that maybe we have taken in the developed West, and are therefore able to use, let's say, health technologies in a way that we haven't imagined. So great examples of that, you look at something like the Zipline drone delivery service in Rwanda. So actually Zipline, the first company to get a kind of an at-scale drone delivery service going before Amazon. They can get blood supplies to hospitals that need them in 15 minutes in a process that used to previously take minimum 4 hours. That's not happening in the UK. That's not happening in the States. That's happening elsewhere in the world, because there's a different set of conditions and there's a different set of needs. I think coming back to that question of whether healthcare is a right, I think if you come from the UK, because of the NHS, there is certainly a sense that yes, it is. But actually, I think internationally, it's less about whether it's a right, and it's more about changing expectations. I think there are lower expectations that you can get really good quality care for chronic conditions. Certainly people's experience doesn't tell them that you're going to get access to really great quality care for chronic conditions like Parkinson's, for example, wherever you are in the world. And it falls to organizations like ours, so a non-profit of kind of 40 million income, to plug that gap when our NHS is serving a kind of multi-billion pound exercise in serving acute healthcare. And there's a real imbalance in how you meet that expectation and that need that I think technology is really going to help us deliver at a scale that we just haven't been able to.
And when you think of neurological technologies in particular, do you think any of those that have come to your attention truly empower patients? Do you find them empowering? Because there are concerns also that we because they interfere with human contact, and as social beings, the most empowering thing for human beings is the affection of each other. Don't you think some of these technologies are potentially disempowering?
I really don't. I really don't, because I think most people's, certainly in the UK, experience of dealing with doctors is not necessarily a pleasant one. It's not a relationship that is on an equal basis. It's expert, idiot, frankly.
So let me make it more concrete. Say in my society, my traditional society, usually the aged, people that are elderly citizens, they get taken up by family members. Same with Abhijit's traditional society as well. In the West, we're seeing increasingly this disengagement and this fragmentation of families, particularly the extended family system, is more or less gone. Now, some argue that rather than this aggressive investment in technology, new science, what about thinking about, human-to-human connections? Because if somebody suffers from Parkinson's, they need those they love most around them. Technology is not going to fix that.
No, I think it is. So I just don't agree with you. Do I think in an ideal world people would still be surrounded by their family late into life and they would be cared for and they would have fantastic relationships with each other? Yes. Is that the truth for most families today? No. Will it be again? No. What can you do? Well, you can use technology to reconnect people so you don't have to be in the same physical space. I'm quite hopeful that some AR technology will make it feel like those loved ones are near you, even when they're not. I do think that in terms of being able to stay in your own home rather than having to go into care, there are technologies now that through sensor-based home management can alert people to look after you if there's problems. For example, you have left the oven on, it can turn itself off, or you have fallen and not moved for a few hours, somebody will come. Robotics that can help you get out of bed and maintain your independence. I think those things are really
less
valuable.
power to the NHS, more power to Google.
Maybe not Google, but yeah.
Any views? I mean, anybody here has a strong view whether they think, this aggressive investment in technology is going to deliver the outcomes that we expect, or have a completely different view, think that we are a bit too idealistic about the role that technology can play in empowering people.
Yeah, Bright,
You have a view?
Does anybody else have?
No, you can go ahead.
Okay, so it looks to me like in the developing world, we're spending a good deal of effort focusing on technology, which can be cheaper than some of our other solutions in the developing world. So we've used technology to do a few things. So for example, we've got technology that will remind a pregnant mom out in a remote village that she's due for a prenatal visit. We've got technology that will help facilities that have never known what medications are on their shelf now can keep track and order the proper medications and enough so that you don't have expired stuff at the end of the process. And so we've got that. We've got telemedicine, which is a fabulous breakthrough for somebody in a remote village who can maybe get an opinion from a doctor in Nairobi. That's wonderful.
But traditionally, when you look at the technology curve, it tends to be the case that over time, the bigger corporations dominate all of it. You don't think so? So you're going to have the bigger corporations eventually dominate all of the technology.
But is that a problem? I mean,
do you think it's a problem?
No, I don't think so. For example, it struck me a little bit to hear, I'm a medical doctor too, that doctors where in the world, in this case in Africa, are striking and the mortality percentage is higher. So a robot will never strike, for example. There are technologies, if it's Google, if it's Microsoft, whoever, The biggest companies in the world, MedTech and pharma, they make it possible that I can operate on a patient. So they will always be influencing on this matter. So the interesting thing is, for example, within 2 years, colleagues of mine can operate, for example, from Amsterdam, a patient in Africa.
Yeah.
That's going to be very, very interesting. So
It's already happening.
exactly. So then you don't have to think, well, are they going to strike, or is there a good doctor? Is there a trained doctor? Is there a trained nurse who has got to do the C-section or this groin incarcerated groin hernia? No, a trained surgeon can do it cross-border, and that's going to be very interesting. And of course, somebody has to pay it, and somebody is going to use data for it. But if you want a robot to operate on a patient, you need data. Otherwise, a robot cannot operate.
What,
But
and if
I'm
there's a
not
malfunction in this kind of world, Katrina, if there's a malfunction in this kind of world, where does the liability lie? Now we know it's a person. We understand the systems. Now you have a system that perhaps is based on algorithms sitting in the cloud somewhere in Spain. The patient is in Africa. There is a malfunction. Somebody really, really gets sick because of that malfunction. Where would the liability lie? Is that not a problem for the rights perspective?
Well, I mean, first, I think to the technology issue, I think I'm worried that this might increase existing inequalities in health because, I mean, arguably, in order for technology to work, you need one thing that is electricity. And too often we go into low-income countries and people sit there in front of black screens. So clearly, this is not a solution that works in all areas. And if it works only for the rich in these disadvantaged countries, then we may actually take a step back by promoting these kind of technologies. So I think that discussion needs to be different between different settings.
Abhijit?
I want to respond a bit to what Katerina said. I mean, I think there are really two conversations here, and one is I think there's technology. There's the cool of the technology, and the cool is very seductive. But I think a lot of the technology that is actually usable, sort of the stuff that Lynn was talking about, these are potentially technologies which are not very cool. They're really very basic, but which strategically used can be very powerful. So the one we are working on, hopefully will succeed, is to just create basically decision support systems for people who are barely literate. These doctors I was talking about who have no particular competence in healthcare, but you could sort of, if you say somebody comes in with chest pains, what are you supposed to do next? They put it in, it gives you an answer, they can follow routines. And we feel that they are pretty willing to do those things. So I think that's totally the opposite of cool. It's not a robot. It's really like the most basic thing that can live on a very low quality telephone, but it could actually save lots and lots of lives and would actually reduce inequality.
But some will argue that does that not take away the role, or rather does that not absorb the government of its role in ensuring that the training schools do a good job? I mean, why is a robot telling a doctor how to do diagnosis if you have medical schools in that country? Shouldn't you, after 7 years of medical school, be able to do a good differential diagnosis? I'm just pushing back at you.
Well, I'm saying that most of these people I was talking about actually have not been to medical school. They've not finished high school. But they practice healthcare. This is, as I was saying, 89% of all visits are to these people. So you better do something about them. And one thing you can do is actually make them a bit better. And the way you make them I think technology can be very helpful in making them better.
It's a good point. 75% of people in Uganda get their their healthcare from traditional practitioners.
Yes.
These are like herbalists, shamans, not from the allopathic medical establishment. So, any comments still? Please.
So in banking, the industry made remote countries bankable. All of a sudden, the bankability of Indians got up in remote areas by a tremendous amount. Give us a number with that simple technology like information on smartphones, or shamans, or people in remote area, or anti-linking. Unlocking information to all the doctors. What's the percentage we can expect? What's the rate of improvement in healthcare that we can expect from cool or uncool technology?
Well, I think maybe you gave the answer itself. There are 3,000 healthcare professionals in your country.
Medical doctors.
Medical. On a population of?
28 million.
28 million. So maybe the
Almost
debate
1 to
is
10,000.
yeah, maybe
Almost
the debate is different. There are not enough healthcare professionals,
Absolutely.
and that's the problem. So um, I don't. So maybe it's a good thing that you just can walk hand in hand with the robot. The robot is helping us because of the fact there are only 3,000 healthcare professionals. So in a population of 16, 17, 18, 20 million, that's not enough. That's insufficient. So and that's I think the answer of the problem.
Self-evident.
Yeah.
So I guess what he's saying is that the sheer number of, say, procedures that you can perform with current technology can exponentially increase with new technologies, particularly where you have cloud systems as well, and therefore you don't have, and that is a potential. I don't know whether to get to mobile banking, because to my mind, health is more regulated than banking. I'm not sure what you think of that, but I would think health is probably more regulated than banking. Any other views? Okay, so
So
Lynn, please
I'd
go
like
ahead.
to ask a question
Yeah.
of the panel, maybe, because this is something I don't really know a lot about. So to the extent that we feel the need to rely on AI going into the future, and Katerina talked a little bit about this, have we done a good job? I think the answer is no. Have we done a good job of making sure that the information going into systems reflects the population? Because right now my understanding is that the data going in sort of reflects, in the U.S. example, reflects the white male population. So you're using a white male system based on data from a white male population to take care of, let's say, pregnant women who are never involved in, clinical trials or that. So it doesn't help people who don't match the profile of all the data that's been stuffed into that system. Have we done a better job of making sure that AI is going to reflect the population, I guess is my question.
I mean, I'm sure there's a lot of views on the panel. My own perspective is that when it comes to this particular problem, you have two dimensions. You have the dimensions of the programmers and the expert systems builders, where not enough of them come from the communities of need. Because these are highly technical areas. The advanced statistics that you need to be able to do good AI. Simply, you don't have that statisticians in my country, for instance. There are that many of them. So you could have a lot of computer programmers, but you need some domain expertise in this kind of area, which is quite lacking. The second question is whether indeed the way they've been sold as capable of learning is actually true. Because if they are capable of learning, then if they are deployed in a particular community, they should learn. They should be able to pick up the cultural traits and over time evolve. But we are not sure. Thoughts? Starting with Katrina.
Well, I think, that's a very good point, I think. And we need well-designed studies in order to evaluate interventions. And obviously, it needs to be drawn, the samples that we study need to be drawn from the individuals who will profit from an intervention. That's clear. I also think it's incredibly important to work in multidisciplinary teams and to work across countries. When we do research, and we at Imperial definitely always work with country partners that make sure that our research is grounded in the realities.
Julie, any view?
I think the only thing that I would add to this is that it's the kind of second stage of learning that I think we'll really find out whether this approach of feeding the system with data and doing machine learning really does improve health outcomes. Once we've done the first round of that, seeing what the outcomes from that first round of data going in and recommendations coming out, seeing whether those outcomes really did improve across a vast and diverse range of people, then we'll know whether the data that's going in genuinely reflects the population or not. And I think it's going to be really hard because I don't think the people feeding in the data are going to fess up if it isn't in the first instance.
But are there any ethical guidelines that we should be developing? Because some of this stuff is uncharted terrain.
I think absolutely. That's going to be the debate for the next 10 years, because the robot, for example, if a robot is going to operate on a patient, he has to learn it from surgeons, for example, and not one surgeon, maybe the 2,000 best surgeons on the world. However, if a robot operates on a patient and within 24 hours this patient starts to bleed, whose fault is it? Is it the fault of the
Programmers,
the programmers, the
surgeon.
surgeons, etc.? So that's going to be a very interesting discussion, because an operation is not a standard procedure. Every operation, something happens that you have to adjust. You have to do something else. You have to start with plan B, C, or D. So that's, I think, is going to be a very interesting road for the robotic surgeons. Absolutely.
Abhijit, what are your perspectives in this regard?
I guess I mostly it's not something I've thought about, but that never stopped me, so I'll continue. So it seems to me one thing that's very, very interesting here is the fact that in terms of AI, I think we have we assume that experts make good decisions. I think there's lots of evidence now that experts actually don't connect all the dots. So I think even if you just put in the information that you are hearing into a system and have it spit out the answer, you get different answers from that. People actually don't process all the information. If you are a top surgeon, you've done this 1,000 times, you don't hear something that's key because you've heard this 1,000 times. And so I think one of the great power of AI is the discipline of making sure that everything that was said is recorded and just fed back. So this is not high tech. This is just the fact that you are now integrating information, and I think it's very hard for human beings to do it actually.
And it also boils down to control. The issue of at what level do you have sovereignty in the system?
That's right.
Is it at the level of the broader medical system? Is it at the level of the professionals on the ground? Is it at the level of the person making interventions? And I guess one of the challenges that, there is a gentleman that in the UK probably know very well, Christopher Hitchens. And I think one time he said that whenever he's introduced to a powerful person, he asks one question, how do we get rid of you? And if he doesn't get a good answer, it often means that there's a problem down the line. So how do we get rid of these systems if they don't function well after they've integrated so deeply? Because that's what we found with all the too big to fail systems. Once they become very embedded, it becomes almost impossible to reform. And we've seen that with the bureaucracy in public health systems around the world. And now we are trying to introduce new technologies. Some of it is moving to the digital ecosystem. But there's almost no idea of how do you pull the plug. Is that not something that gives you some anxiety, Lynn?
Yeah, I would take that as I would take a step back. And I'm going to pick on Katerina for a second. So Katerina said something really interesting, that we shouldn't really be talking about health care. We should be talking about health.
Or sick care.
In the U.S., we don't talk about health. We don't talk about health care. We talk about health insurance. So we've taken it a step further. And so talk about being stuck in a system. We can't even have the conversation about health. We are so far removed from that, kind of scrapping the whole thing and starting over is the only way I see out of that. So, you talk about being stuck. We're so stuck, and we're so far beyond having the right question. I don't even know how to frame that, though. How do you talk about health when you are just so many steps removed from that? It's baffling to me. I've been thinking about it for about 25 years.
If I can offer an answer, I'm not an expert on the US system, but certainly what does work is the involvement of patient organizations. And I think, taking a step from health insurance back right to the point of need means making more space, building more conversations, more collaboration between patient organizations like charities or like independent bodies of patients who have self-formed to put together, their view, and involving them in all of the discussions and finding ways to do that at scale is, I think, the only answer. It's something that we've had some success. We put together a thing called Critical Path for Parkinson's, bringing 10 of the major international pharma companies, a bunch of patient organizations like ourselves, and then the NHS, some American health insurers to have a joined-up conversation about what the priorities are, how to fund clinical research that really meets the point of need and is working.
And I think what's important is to have an explicit process how priorities are set.
Yeah.
That I think is lacking in the US debate. No, I mean that we have much more. I think in the UK where there is an organization even in place to decide what our priorities should be and in which areas we should invest. But I think that is something that will come in the US as well.
Yeah, and I said I wasn't going to talk about the U.S. So I'm sorry I brought it up.
But I mean, we've been having the discussion in a fairly apolitical manner, with an assumption that everybody's doing their best. It's just a very difficult problem. But there is also a perspective that there are people or there are institutions or groups that are actually detrimental to the ecosystem. And pharmaceutical companies, who are actually some of the clients that I have said for a while, tend to fall in that category a lot. I mean, the eyes of activists, they couldn't do a good thing. Then recently, there was this incident where one of the biggest pharmaceutical companies, they had a problem because somebody was trying, or a group was trying to get one of their patents overthrown, overridden by the court, actually with the patent office. So they gave the patent away to a Native American tribe and then licensed it back. Because in the US, the Native American tribes are more or less sovereign. So the patent office has no power in those territories. And to be able to then do what the group was trying to do, the activist group had to do, they have to go to the court. Sounds like perverse creativity. Do we think that there are established organizations or interests that are somehow organized against patient rights in some way, and that the interests they have are just not compatible? Do we think that, Abhijit?
I mean, the one maybe most delicate one, since I have a way of throwing a spanner into the works, let me do it again. Other doctors, I mean, you basically, in the US, you have this whole battle where, every new technology which will save somebody's life for 6 hours, the doctors have insisted, basically, that those technologies have to be accessible to patients, even though then the costs go up and exclude people, and that makes healthcare unaffordable for many people, and they die. But you have a brutal trade-off there, which seems to be entirely built into the system, because no doctor is willing to say that this isn't worth it, or at least the health, maybe the pharma companies don't let them say. It's hard to know who's playing on that particular game, but
So Hans is itching to respond.
Yes.
And we have very little time. So Hans, you have the last word. And maybe, does anybody really have anything to say? Okay, so Hans, respond, and then I go to the audience and I wrap up.
Well, I understand what you said, and absolutely, interests are different. Investments in pharmaceuticals and medtech are extreme. However, without these big companies, we cannot treat patients. It's very simple. Also, to answer your question, what happens, or robots are already operating in the operations rooms. We are doing assisted surgeries. So it's just a matter of time how fast it's going. And of course, if some big problems occur, then we have to take a step back. But this is something that's going to happen, and we're not going to, I don't think we're going to stop in this very interesting motion.
Thank you. Last word, sir.
Thank you. I'm a doctor, and this is my first visit to this summit, and I'm very excited. There's so much is happening. This is the first health forum that I'm attending, and there's very little on healthcare. I come from a country where there is very little money.
And this is India?
I'm India.
Okay.
And I practice in a country where there's a lot of money. But in both places, I don't have access to information in time. But I have every access to information about anything. I can find out your phone number, which I got an email about 10 years before, in a few seconds. But when I'm operating, and if I want to know what size cup I put on the other hip, I need to wait for 4 hours or 5 hours. If I want to switch on the computer in modern hospitals, it takes 7 minutes or 14 minutes to switch on. And there is so much security, so much... see, the availability of information is so hard to get in anywhere in the world. The corner shops have a better system, better hardware. the hospitals don't have. And people probably don't realize the information, access to information is so hard inside the hospital. And restrictions, legislations, everything comes in the way of me getting. The only person, even today, majority of the hospital use paper system. It is very difficult to get information in real time.
Yeah.
And we are talking about technology, robotic. No, I mean, I don't have a fundamental access to my patient that I have in front of me. And if I want a system beyond 7 years, I don't have the chart. The chart is in Iron Mountain or somewhere which is about 70 miles away. So I think we are forgetting the basics.
So it's a return to basics.
Sir, this is basics. I don't think in healthcare, even here, the healthcare area is completely ignored. Everyone is talking about excited apps and software and technology for every other walks of life. But every human being have a story, a health story, from the day he was born and from the day he dies.
Thank you
but
very
none
much.
of the industry seems to be interested in that.
Thank you.
I want
Thank you.
the
I think it was a
panel's,
good note.
view.
It was a good note to end on. We are 2 minutes over time. So thank you all very much for
Thank you.
making time to attend our panel. We're very grateful for your attention.